in King Fahd Hospital, Madina, and the organizing committee. I would like to welcome you in Al Madina Breast Cancer Conference. It is a great honor to have the international experts in Saudi Arabia for treatment of and management of breast cancer. With us in this conference to discuss the last updates and international recommendation for breast cancer. Inshallah, we will have a comprehensive session in treatment and management of breast cancer, starting from the screening and diagnosis till the treatment of all stages of breast cancer. I would like to thank all speakers for their participation in this conference, and also special thanks to Saudi Oncology Society, SOS, represented by the chairman, Dr. Adnan Al-Habshi, for his support for this meeting. Also, I want to thank all the attendees for attending and our guests for accepting our invitation. Dr. Mirvat Mahrous and the organizing team for their effort in organizing this meeting. Roche Company, our partner, for their sponsorship. I hope that we will have the maximum benefit, and for our guest, pleasant stay in Medina. And I would like to welcome the first session chairman, Dr. Al-Khair Abu Khair, consultant medical oncology, Princess National Guard Hospital, Riyadh, and Dr. Samira Suleimani, breast imaging consultant, King Fahd Hospital, Madina, and Dr. Hafiz Ghanim, consultant clinical oncology, head of palliative care in King Abdullah Medical City, Makkah.
I would like to thank the President Committee for inviting us to this meeting in Medina. Our first speaker will be Dr. Mirvat Mahrous. Dr. Mirvat Mahrous graduated from Qasr Aini, Egypt, then she has a fellowship in USA and Canada. Then she joined King Fahd General Hospital in Medina. She is consultant, head of the medical oncology department, King Fahd General Hospital in Medina. Please, Dr. Mirvat, she will talk about what top news of the year, what did we learn from 2014. Please, Dr. Mirvat.
Thank you all for coming and participating. I'm very grateful, and I'm very grateful to our team. And I know that it's weekend and you have a very busy schedule, so I didn't want to make it hectic for you. It was lovely to have you, and I think it's the spirit of Medina, just make everybody and be as a partner and doing this. We are very grateful to the department, and we're taking to the next level. And we are very grateful to Dr. Magid and his enthusiasm, and for our tumor board committee, Dr. Ghassan, Dr. Samira. We had a lot of arguments and also a lot of discussions, and I think it will be helpful for all of us. My talk, it will be top news of the year, so I will not go for details. I just will excite you more about what is happening and what will be done or what will be discussed in the meeting. I'm sure that in every time when you are going to the conference, you are trying to find what is new and what is coming, so you can change your policy or to keep the same. So when I got this topic by the scientific team, I was thinking what's supposed to say in it. So the first time that I was thinking, okay, so I will go for the top breast news. Sorry, can I have a pointer? So it was my first thought that maybe I will go for the one who by the website. And then I thought, no, we have to just think about the ASCO and ESMO and everything EPCC. And we have a lot, actually. So what did we learn? As an overview, I will go first with the websites, then we'll go for the what's new in the conferences, and then what would we learn from to 2014. So the top 5 breast cancer news in 2014. If you are Google for any news regarding the breast cancer in 2014, you will find that the top one, it was the when Angelina Jolie, she is actress and the humanitarian representative, she went to the press in May 2013, and she was spoken that she is BRCA1 positive, and she had the familial breast cancer, and she had the chance of breast cancer more than 90%. Her inspiration doubled the visit for the familial breast cancer and create a point that most of us, we are thinking that familial breast cancer is considered a big issue. And even it's not only by the breast. We got now that even that you have to look at what is going on for the websites and even for the people so you can implement this in your practice. So you will find that there was a study published in Journal Breast Cancer, and between May 2013 to this time, more than 8 journals, oncology journals, they are making surveys and making reports, and even the impact of Angelina Jolie as an actress. So what is, if you look at this graph, you will find that this was published in presented in ASCO 2014, and it was done by Sunnybrook Cancer Center team, Sunil Verma and his colleague, and they will try to find how it is the impact. So you can just easily find that the reflex was doubled by the news. So it's really our learning point from this, that BRCA1 and BRCA2 patients, they should be put in consideration, and every patient will come to you and asking about the familial breast cancer. We have to make genetic counseling for her. And the other point that we'll found that when they are estimated, and it's published on the Cancer Network, the incidence of breast modified radical mastectomy, it was increased in the last year by 10%. Most of the females, they were a little bit scared from this point, and this inspiration made them my health first, and it was even the 10% increase, it was implemented by the patient's choice. It wasn't a physician choice. So what is the second for the top news? It was that diabetes may increase the size of breast cancer and breast tumors. In EBCC, this was 2 abstracts. One was presented by David Cameron and the other one by Fontana. It was mainly that the diabetes can increase the size of the breast cancer, and you have to adjust your patients. And there was an assumption that hyperinsulinemia, it can be an impact of the tumor growth. The next one, it was the certain long time ago we could consider the contraceptive pills. It's not, we're in phase in between. We didn't consider that even it can be an impact on in breast cancer. The UK group, they studied 1,102 patients, and they found that the patient who received contraceptive pills with a high level of estrogen, they have 2.7-fold. So be careful, please, in any patient who have a familial history or patient is receiving contraceptive pills, and even the time they consider maybe increasing risk as well. And this this data was published in Research Cancer Journal in 2014. Skirt size is linked to the breast cancer. We have to make sure that this study was done in 93,000 female, and it was done by the UK cooperative group. Do you believe that one size increase your risk, female risk by 33%, comparable to 2 sizes increase 77%? And even this is what just not only a news. We can see that in the last ASCO and also in the last San Antonio, you'll find that we are not even trying to give the patient medications. We are thinking about the social aspect. We are thinking about supportive care. We are thinking about the lifestyle. When we look at this study, you will find that the obesity, it was studied very well, and you can just see that the early breast cancer trials group, they found that there is increasing mortality in premenopausal patients, and even it was significantly, and it was very, you can see that the hazard ratio for this, the relative risk, it was 1.34, and it was highly significant. It's increasing mortality for premenopausal patients, and it wasn't the same for the postmenopausal. However, if you are encourage your patient for a weight loss, it may be reflect on the patient. They did a thing which is really good. They make two groups, which is weight watch, and they even try to find the biomarkers for it, like everything. They try to see that if the CRP and leptin and many tumor necrosis factors may have an impact on this, and it was significantly that. So if you have a weight loss patient, they are doing diet and exercise. It's the same message. Vitamin D, we are hearing a lot about vitamin D and patient survival. So back to our part. So what's news and what is the news for the ASCO and the ESMO? Of course, for most of the attendees, they are oncologists, and they were maybe very interesting on the point of the what. So if we are talking about early breast cancer, the NSP P36. As a matter of fact, we didn't have much breakthrough this year or the year before, but we do have breakthrough. And the other point that we're trying to even to establish what we are doing. And when we look at this study, you will find that this is the usual we are doing in every day. So they put AC versus FIC regimen and the AC 4 versus FIC 6, and they try to find, and just put in consideration that it's just only for T1C, and this is for node negative patients. And you can just easily find that there's no one can be even think that it was no significant benefit. So you can decrease the timing of the chemotherapy without affecting the patient outcome regarding the PFS and OS as well. The second point that the toxicity was, of course, for the arm was epirubicin was in high side, which is 100, and you don't need it. The second part is the trastuzumab. If the trastuzumab, we are using a lot, of course, and if we are thinking a moment, we'll see that the trastuzumab is changing part of our history. And if we are practicing oncology 20 years ago, speaking to myself, that you will find that the patient definitely is changing the era for them. So this is the meta-analysis for HERA and the 5 common and biggest groups. So of course the highest one is the HERA study. Thank you very much. So the highest one, it is the HERA and NCTC, and you can just see this numbers. So if you look at this numbers, that's not okay. Yeah. Okay. The cumulative risk, you can easily find that there is difference between, and there is a benefits, 8 years gain, 7% comparable to, it was 24.3 versus 17.3, and you can easily find it. And even for the cumulative recurrence as well, you can just 24 versus 33.4. Of course, the trastuzumab arm, and when you look at these numbers, you can just only see that you are doing a very good job. And every one of us who is treating patient with trastuzumab and HER2 positive patient, you can see there is much difference. Of course, we have some resistance, and of course, we have to select our patient, and we should know this. So how about if we are combining the trastuzumab plus or double blockade? It will affect the point of the adjuvant therapy. Unfortunately, this study it was multi-centric study, and they trying to answer the question. And based on the new ALT study, the PCR, they just try to find that the double blockade may be affecting the patient outcome. So it was trastuzumab, lapatinib, or sequential. I will not go for the details. I know that you are. We'll see a lot in our meeting. So as a short, if you are doing a double blockade, you can see that even here it was 0.448, which is it was 0.48, but it wasn't significant based on the pre-analysis, and it was pre-identified analysis. So it's mainly that increasing toxicity without adding any benefits. So, of course, the toxicity was higher in this part, and it's very expected. And believe it or not, that trastuzumab was doing even better than the other arm. So, back to the hormonal therapy, which is the main part for us. So, the soft and the soft trial. We are waiting for the soft trial long time ago. We're trying to find that if you are castrated the women and adding tamoxifen, it will be affecting their outcome or not. So this trial, even it was a negative trial, but it was having a lot of message. If you look at these numbers here, so if you look at here, you will just find that the 5 year it was 84, even for tamoxifen. And some of the patients only they will receive chemotherapy, but most of them they receive tamoxifen of ovarian suppression and exemestane as well. So you can just find that this number is really promising. This means that we are doing a very good job regarding this patient, and we are affecting our patient outcome. So look at this. You can just find here 97.1. You have 99.3. This is 5-year percentage for the patient with no chemotherapy. This is a really good message for us and previous chemotherapy. So the patient who didn't receive chemotherapy, this means this patient, they were more than 40, they were 91 node negative patients, and with 85% tumor less than 2 centimeters. This is the criteria where I would consider this patient low risk, and they were totally get benefit from the treatment, and this numbers is really promising for us. I'm not over-optimistic, but at least we have to just have a moment to think what you are doing is right or you need to reestablish. And I think this is what the main point for these studies. They try to find the tamoxifen and the hormonal therapy we are using a lot for the patient. So it may affect their impact or improve or not. This is supposed to be the big answer and be asked. And for the joint analysis, you will see that in the text study, the patient they started the ovarian suppression from day 1, comparable to the soft trial, which it was more than 12 weeks to start. So there was difference between the studies. We don't know that may be affecting or impact their outcome or not. But for sure that if you are doing castration for the patient or give them GnRH analog, it may affect them. You can find easily this number. It's 5-year disease-free survival, 91 over 87. It's really a good number, and you can just favor for exemestane. But you have to select the patient who's supposed to be candidate for exemestane, and young patients, aggressive disease, they are supposed, because there is a lot of side effects, and we have to consider it carefully. One of the elements we talk about that we have to think about the patient not only for the point of the disease, we have to think about it as a person and they have a life. So this study, it was the one addressed by ASCO 2014. They were thinking about the fertility for the ladies. They start for them Gorazan, GnRH with the chemotherapy to keep their fertility, and they randomize the patient, and it was a phase 3 study. It was randomized to have chemotherapy versus chemotherapy with Gorazan from day 1, and the primary endpoint for this patient was failure of ovarian failure in 2 years, comparable to, and second endpoint it was the number of babies, and it in the history that number of babies can be endpoint in breast cancer. So for this study, you can find that this number is amazing, that you can just find there's a difference between the two groups significantly, and you can see that the 2 years, 45 versus 20 for the patients who have a standard chemotherapy comparable to the chemotherapy plus Gorazan, and you can see that the 1 year it doesn't make difference and 2 years make a difference. This one is really something, that it was not pre-specified analysis and it was hypothesis generated, but it's affecting the disease-free survival and overall survival. So if you have a patient and she's a young lady and she's seeking for pregnancy, and you just be considered this patient, they are hormonal negative. So they if you start for the, and we have to put in consideration this was small study, but it was a hint and a signal that you can give to the patient. And we are waiting for a big randomized analysis to validate it and to compare. And it's very tolerable as a message. I will not go for the details for this one. We have one of the points for the new in the conferences this time is the basic science, and the other points is the genetics, PI3K and PDL1, and you can just find. We started when I was a resident with the hormonal receptors. Then it was followed by the HER2. Then it was the theory of anti-angiogenesis and VEGF and microvascular dynasty. Now the fashion of the year is the PI3 kinase and PI3K and also the PDL1. And we are really, once we have started to think about it and to understand, we found another genes with another explanation, and the closer we are, we can just only be more confused. So it was the PI3K inhibitor combined with the hormonal, and we will see that the astonishing part, you can just find that in the luminal P type, it was even better than the luminal A. Do we have any news regarding the advanced breast cancer? Of course, we are thinking about the carboplatin in the triple-negative patients. We are thinking about the carboplatin-induced Taxol. Carboplatin has a lot of talk these days regarding BRCA1 and BRCA2, but unfortunately the study was negative. But we got a message from this that the carboplatin may be for the PRCA mutation. You can see that 6.8 versus 4.8, and even you can just think that PRCA1 patient can be candidate for it. First study. Okay, I will just. Okay, so just give me 1 minute. I will conclude. Thank you very much for pointing this. So the first study, it was only the anastrozole versus fulvestrant, and we can see that fulvestrant. So the Cleopatra study, it is a study for the adding Perjeta 2 and the double blockade, and it was unprecedented. The first time that you can see this number in a metastatic patient. 56.5 versus 40.8, and even 40.8 is a good number. We have a 16 months difference. And with this study, I will just conclude that we have a lot of progress, and for the sake of time, this is the most common and token studies. So what we learned that familial breast cancer has a lot of attention. We need to have an action for this for women. Lifestyle change only can impact the health of the patients and also their behavior and even their outcome. Fertility is considered to be an social aspect needed to be discussed thoroughly with the patient, and adjuvant treatment AC/4 you can just it's good as 6 cycles of FAP. Trastuzumab still going and improving DFS and OS as well. Pembrolizumab did not improve disease-free survival and is still questionable, and additional of to adjuvant therapy doesn't have an impact or improving the overall survival. We still are waiting for the CDK and PI3 kinase and PARP inhibitor. Thank you very much for your attention.
Dr. Anand, she is a woman imaging consultant in Abdulaziz University in Jeddah. She has a fellowship in Madina in Canada. She will talk today about breast cancer screening by MRI versus breast cancer screening in mammography. What is available?
Thank the organizing committee for the invitation. It's a great honor to be with you here. I'm going to cover today breast cancer screening, mammography versus MRI, and it's an extremely interesting topic because we always get the questions and we have the discussions about what should we do for the patient. So I think it's extremely important to know the details of the screening guidelines that we apply in our institute and over international institute. Okay, so I will talk about screening breast cancer with mammography has shown significant reduction in mortality, and we all know most of the studies, the randomized control trial has shown 26% reduction in mortality, and there is a recent study that showed up to 39% reduction in mortality in cases of breast cancer. and we all know that mammography is the mainstay and the most important diagnostic technique that we use to screen for breast cancer. However, with time and with advancement in radiology and in medicine, there has been several development of several diagnostic modalities that came out. One of these is MRI, and it has shown, several studies shown that there is significant improvement also in reduction of mortality with the detection of breast cancer with these modalities. I'm going to talk mainly about Society of Breast Imaging and the American College of Radiology guidelines. I'm going to touch in the screening guidelines that they have recommended in 2009, and this is the last update. And I'm going to touch quickly at the end about our national screening guidelines that developed by our clinical practice, for clinical practice by our Saudi national group. Okay. They divided the screening guidelines based on two things. They divided based on imaging technique, when should we use mammography and when should we use the other imaging modalities available. And this includes predominantly MRI, and then they added other imaging modality like ultrasound, and they talked about them. And then they divided the guidelines also based on the patient risk factor. So I'm going to touch on both, and I will combine both so we can get a full idea about how to use both of them based on the patient clinical history and patient background. So talking first about mammography, so they divided the patient into two groups based on their age and based on their risk factor. So women at average risk for breast cancer and women at increased risk of breast cancer, and we have multiple subgroups under this group. So for patient with average risk factor, they will go for annual screening at age 40. Lots of questions came up. Why should we start at age 40? Why we should not start at age 50? And when should we stop exactly the screening? So this we're going to touch on too. And for patient with women at increased risk of breast cancer, should we screen them before age of 40? So as I said before, several randomized controlled trials. As I said before, the several RCTs supported the recommendation on regular periodic screening mammography, except only one that showed no significant decrease in mortality of these patients, and came up with, during the discussion of the screening, the United States Preventive Service Task Force in 2009 came up with a new recommendation, and this resulted in significant argument and discussion in the United States. And this discussion and argument came back to us in Saudi Arabia because we are North American trained and we follow all of that, so it was significant discussion about that. And they said that we should not start screening at age 40, we should start screening at age 50. And they also harms associated with all the imaging tests that we do. We do mammogram, followed by ultrasound, followed by biopsy, followed by MRI. And then patient is exposed to significant multiple imaging tests. They found that after all of that, patient will go through significant anxiety problems, and then we will have significant false positive result. So they said, based on that, outweighing all the benefits that come from 15% reduction, they said there is no need for screening from 40 to 50. So they said also that screening from above age 50 to 74, it will result in 81% reduction in mortality, preserving the 81 reduction in mortality. So we're getting the benefit in 81% of these patients. While starting at age of 50, at age of 40, it will add only 3% increase in reduction in mortality. So despite of all of these data that goes with screening with mammography, they suggested that screening should be done at age 50. And according to these recommendations, there was significant, as I said, significant argument and discussion among the group of oncologists and among the radiologists. And in United States, in North America, they came up at the end to conclusion that they should start screening these patients starting at age 40, regardless of the USP, Preventive Task Force recommendation. So they completely ignored these recommendations, and they stick to the old recommendation that were done by the ACR and the Society of Breast Imaging groups. So when should we screen patient before age 40? And this is an extremely important question because we get a lot of questions for these patients. So the American College of Radiology and SPI, they identified specific subgroups of patients, and these include predominantly BRCA1, BRCA2 patients, and anybody who has relative with these positive genes with a first degree relative, they have to go for screening before age 40. So when should I start screening these patients? At what age? So people sometimes they start screening them at age 25 or age 30. So it depends on the institute and it depends on the United States, usually depending on the insurance company. But we do screen them at age 20. We can start screening them at age 25. Should we start screening at age 25 with MRI? Yeah, of course, this is a discussion. So because young patients, when they are 25, they have an extremely dense breast, which makes the sensitivity of mammogram is extremely low. So we do recommend that from age 25 to age 30, we start screening them with MRI. When they reach age 30, we start screening them with MRI and mammogram. And you will have the question, why should we do that? Because MRI is an extremely sensitive modality, however, the specificity is low for MRI. The other thing is we know that there are some DCIS type of cancer, they are occult and we cannot identify them on MRI, so we have to do mammogram to identify the microcalcification on the mammogram. So in conclusion, I would say for these patients, BRCA1 and 2, we start screening at age 25 with MRI, and when they reach 30, we start MRI and mammogram combined. Second subset of group is these patients with 20% lifetime risk for breast cancer, including family history coming from maternal or paternal. So these patients, when should I start screening them? So if we have an identifiable time that these patients they have breast cancer in their mother or sister, so we usually screen them 10 years earlier before their mother or sister. Let's say the mother, she developed it at age 30, so should I start screening mammography at age 20? Of course not, because at age 20, again, she has an extremely dense breast, she has a very sensitive breast radiation, so once from 20 to 25, we'll do MRI. After 25, we can start a mammogram, and then we will combine it with mammography, with the MRI. So these patients, 10 years earlier from their relative, and we have to start before 40. So this is again included in the first group, and then women with history of mantle radiation, and these are usually young patients. They develop non-Hodgkin lymphoma, and they have been exposed to radiation for the mediastinum during early age. So these patients, they have an extremely increased risk of breast cancer by age of 40. So they have more than 20% risk of breast cancer. When should I start screening them? We start to screen them 8 years after the development of radiation. So if they have been exposed at radiation at age 16, so 8 years later, age 23, they will go for screening. Again, the question comes, should we screen mammo or MRI? So as a rule, I would say mammography is nothing before 25. Anything before 25, if the patient needs, you have to do it MRI. After 25, then we can do MRI combined with mammography. So a quick touch on digital mammography versus film screen mammography. So we are lucky enough that we are an institute. We have digital mammography, but I've worked in several institutes. They have still old films. So which one is better? I would say based on literature review and multiple studies, they found that digital mammography and film screen mammography, there is no significant increased detection of breast cancer on the two modalities, but there is improvement in detection in subset of patients, and these include patients with extremely dense breast. So it is good for extremely dense breast, but otherwise they have similar detection rate for breast cancer. Just looking quickly at this image, I always like to look at this image because it is extremely reflect what we are faced with when we look at the mammogram. This is a very clear sky, so when we have an easy breast, and what I call an easy breast is a predominantly fatty breast, you can see everything through it. When you have a little bit of clouds, then you don't see what's behind that cloud, and when you have a cloudy sky like that, you will not see anything beyond that. And that's exactly what we see on our mammogram. We are lucky enough to have digital screening mammography, so you can see how crispy clear the image is. If you have a fatty breast, you can see everything there. If you have an extremely dense breast, and I've seen tons of cases, there are cancer there and we cannot see it at all. So when you have a screening mammography for a patient like that, is it digital versus an old film screen? Then digital definitely will be better because I still see the details in between, and then I will do an MRI to evaluate that breast better. Moving to screening breast MRI guidelines. So I'm talking here mainly about the guidelines that came from the American College of Radiology, and they have seen several RCTs has been done, and all of them showed increased detection rate of breast cancer using MRI. The only problem with breast MRI, as I said before, is it is an extremely sensitive modality. It picks everything. You will see tons of enhancement, and it has specific features, and if it does not correlate with whatever I have on mammogram, I might call there is a malignant features and I have to biopsy that. So it definitely will go up with your false positive rate and with your biopsies numbers. So the only withdrawal of breast MRI, it is not very specific. So we always have to combine it with other stuff, with other modalities to make it more specific for diagnosis. So 2 questions comes when we talk about screening breast MRI. When should I use breast screening MRI and what age should be used? So I touched a little bit when I talked about mammography, but I will go in details. So based on ACR and SPI, they suggested annual screening mammography for women aged 20 with annual mammography for patient with 20% increased risk of breast cancer. And they have to go also for annual screening MRI associated with mammography, as I said before. As we said again, BRCA 1 and 2, they have to go for annual screening breast MRI beyond age 25. So we have to start screening them at age 25. Patient who has family history that may suggest genetic predisposition, there are subgroups of that. All of them, they have to go for screening breast MRI. And as I said, when should we start screening? At age 25, and we combined it with mammography after 30. Second point, I forgot to tell you here that the ACR and SPI, they divided their subgroups into 3 subgroups. They talked first about patient with 20% increase in risk. So this is the first subgroup that they talked about. And then they divided the second group. What should they do with patients who have 15 to 20% lifetime to develop breast cancer? And these patients, they have some of them, they have specific pathological diagnoses, including lobular neoplasia, atypical ductal hyperplasia, or themselves, they have a prior breast cancer, should be screened with MRI. So, the 2 institutes, they did not go with or against screening them with MRI, and they left it to the referring physician. And they said, if the referring physician did a good screening assessment and a good assessment of their risk, and they have more increased risk than the rest of the population, then they have to go for MRI screening. So this one is left to the referring physician to decide, to the oncologist to decide if they should go for screening MRI annually. The third subgroup of patients that they talked about are these patients who have less than 15% risk. What should I do with them? Should I screen them with mammo? Should I screen them with MRI? So the two organizations, they stated clearly that these patients, they should not go for screening with MRI. So these subgroups, we will not screen with them. We will not screen them with MRI. So again, this is just a summary. BRCA 1 and 2, we start screening age 30. First degree relative, we start screening at age 30. 20% lifetime risk, annual starting by age 30. Just keep in mind, because I talked about age 25 to 30, this is, again, it was emphasized on all the screening guidelines that from 25 to 30, you can start screening them with MRI, but not before 25. So the 25 to 30 is the time that you can start screening them with MRI and mammogram. Okay. What should we do about the patient with personal history of breast, ovarian cancer, And this also includes, they put this subgroup, biopsy-proven lobular neoplasia or ADH. So patient with ovarian cancer, history of ovarian cancer, we have to start screening them as soon as they are diagnosed with ovarian cancer. And we have to do an MRI screening for them as a baseline for them. What about the patient with newly diagnosed breast cancer? Should I screen them with MRI? Even if she has a fatty breast, should I screen them with MRI? So the consensus came up to, even the patient with a fatty breast, we have to screen them with MRI as a first round only. We don't keep screening them with MRI. We just need to do one first MRI based on their diagnosis. And why should we do that? Because they found that there is 3 to 9% increase in detection of breast cancer on the other breast. So we always push for MRI, baseline MRI in patients with newly diagnosed breast cancer, because we have diagnosed patients with contralateral breast cancer that have been subtle and occult on other imaging modality. Okay, sure. One important point that I would like to emphasize, breast MRI is not meant to replace mammography at all. And the reason for that, again, is because we've seen tons of cases and the literature showed that there is an occult DCIS that is not seen on MRI, and we see it only on mammography. So the first screening method and diagnostic method for any breast case is mammography, followed by possibly MRI. When should I do MRI for the patient that we talked? So we decided and we came up to the conclusion that this patient, she should go for screening MRI. So based on their assessment risk criteria, they will go for screening MRI either at the time of the mammo. So there is two schools. Some people, they do the MRI with the mammogram at the same time. Some people, they prefer to do mammogram, and after 6 months they do MRI, and after 6 months they do mammogram. What's the advantage and disadvantage? It depends on the radiologist. When you do it at the same time, you have the ability to compare and combine the finding of the two studies. When you do it within 6 months, then you are screening the patient almost every 6 months. So you are giving more benefit of screening for the patient every 6 months. Okay. A quick talk about breast ultrasound. Does it add anything? If I'm using breast MRI and mammogram for screening, breast ultrasound would not add any increased detection rate of breast cancer. But in cases that I'm not able to use breast MRI, ultrasound shown increased detection of breast cancer in about 2 to 3% of breast cancer detection in 1,000 patients. So if I'm not able to do breast MRI for whatever reason, patient probably she has a nephrogenic systemic fibrosis and she cannot go for breast MRI, at that moment I will combine mammogram and ultrasound, and I will be able to pick more cancer. Just 1 minute, I'll show the images. So this is the interesting part for me. So you see there is a mammogram. This is a patient, she presented with subtle skin changes, and when you have the mammogram, you see that she has a dense breast. You pick that there is probably a mass, you do ultrasound and you find, we did the ultrasound for this patient, we did the biopsy and it is invasive ductal carcinoma. We do the MRI, MIP images, this is the cancer that you've seen, and then there is another mass lesion within 2 centimeters of the original index lesion. So this is a multifocal breast cancer. The second lesion was not detected on MRI or ultrasound. So this is the usefulness of breast MRI. It's extremely sensitive and can pick cancer. This is another case. Patient, she had normal mammogram. You see on the MIP images, you see that there is a focal area of enhancement. You see that there is increased color mapping, red color mapping, wash in, wash out, diagnosis proven invasive ductal carcinoma. So this is on MRI. Look, this is the mammogram corresponding to this image. When you look at the this is the map imaging a year before. You don't pick any changes or any enhancement pattern on this patient. Okay. This is a real case scenario also. You see that she has an extremely dense breast. You see that there is some architectural distortion. So we think that there is a small mass here. We do the MRI, and when you look at the MRI, there is a huge mass with extension, ductal enhancement extending toward the nipple in keeping with DCIS with extensive enhancement. The interesting part is when you look at the other breast, there are multiple areas of enhancement. So all of that, you have to be sure that it is not suspicious, and we have to do biopsy for multiple findings. But when the interesting part is you see something suspicious like that, you do biopsy for that, and it turns to be invasive ductal carcinoma. So we detected bilateral breast cancer with MRI for something that was completely occult on mammogram. Thank you so much, and I will be happy to share questions.
Okay. I'm going to talk about the breast pathology from morphology to the molecular techniques and where are we standing right now. When the treating physician is going through a breast cancer case, they usually look at multiple parameters to evaluate the patients and treat the patients accordingly. These are the parameters that are usually the treating physicians are usually looking for. Look at the patient's age, tumor stage, and looking at the lymph node status, tumor size, metastatic status, and then looking at the histological grades, evaluating the cell type, lobular versus ductal carcinoma, and grade of the tumor using the SPR grading system, LVI, lymphovascular invasion, and we look also for the ER and PR status, and then HER2 status, and more recently, the proliferation index are getting a lot of attention, as I will mention shortly. We use these parameters or these features to routinely make a clinical decision regarding local and systemic therapy that they are using to treat the patients. Typically, they are taken into considerations other parameters like Nottingham prognostic index in NIH criteria, and there are many other criteria as we go. There are still problems with these features that when people are using it to evaluate and treat patients with breast cancers. First is the accuracy on reproducibility of certain pathological and clinical parameters, namely the histological features and cell types and the grade of the tumor, LVI, whether it's there or it's not there. And looking also the tumor size. We have some problem with the reproducibility on these aspects. Also, there are problems with the ER and PR status and its evaluations and the scoring. HER2 status also evaluations. There are some problems that we all as involved in the field of breast cancer pathology we are facing it. And the ability to assess the outcome, to predict the therapeutic responses in individual patients is also limited. We know that, and I'm sure all of the treating physicians, oncologists, and radiologists and surgeons are facing it. A tumor with also similar features that we will look at it and we say this looks like infiltrating ductal carcinoma, ER positive, PR positive, and HER2 negative, and proliferation index is low, and they look similar, but they have a different clinical course and different outcome because we assume they are exactly the same. And let's take you through an example here. Patient A has this breast cancer on the right side, and patient B has a breast cancer on the left side. If you show it to 10 different pathologists, they will call this as infiltrating ductal carcinoma in both sides. There's a lot of similarity for the practicing pathologist. We also look at the tumor grades and we evaluate the grades, and the grades on the left side is grade 2, grades on the right side is also grade 2. And there is the size of the tumors on the left sides is probably, let's say, about 2.5 and maybe 3 on the other sides. And no DCIS is present here, no DCIS is there. And no lymphovascular invasions is there, and no lymphovascular invasions present there. We look also for the lymph node status, and we also evaluate the margins. And more recently now, there are all the pathology reports. They should include ER and PR status, and also they should include information about the HER2, and also information about the proliferation index. And those two breast cancers, they are essentially identical on their evaluation. But when it comes to the clinical outcome and treating these patients, they might have difference. Why is this? Because we assume that breast cancer is the same disease, it's a homogeneous disease, but in reality it is not. And this assumption is probably wrong, because breast cancer is in fact a complex genetic disease. It's characterized by accumulation of multiple molecular alterations. And this resulted in a clinically heterogeneous disease, and existing histological features that we evaluate when you look at them under the microscope do not fully capture all the varied clinical courses of this disease. And then the resulting clinical heterogeneity makes the current diagnostic and therapeutic strategy less than perfect when we are dealing with an individual patient. And pathological and clinical features are therefore considered to be insufficient to capture the complex cascades of events that derive the clinical behavior of this tumor. So what do we ideally want for optimal management of patients with breast cancer? We need to know the ability to distinguish different prognostic groups among patients with similar or identical tumor characteristics. And also we need to know the ability to predict the response to various therapeutic agents in individual case. And that's what we need. And this is the oncologist questions. They need also to know how we can identify patients who are ER, PR positive, node negative, that are at very low risk of relapse, and to avoid exposing those patients to unnecessary, I would say, chemotherapy. How can we predict response to currently available therapy? And also, the oncologists would like to know how to identify tumor targets for directed therapies. And of course, this slide, it shows you that we love classifications. We enjoy doing classifications in our practice as a treating physicians, in our practice as a radiologist, and as our practice as a pathologist, because we want to segregate things, to put them in different categories, in group. And this is probably something to do with our brain, to understand things. And also, it's also something to do with our to understand the tumor, to be able to treat the patients in a proper way, to provide guidelines to treat this patients in this manner and this patients in this manner. And this is the classification. Arranging objects into groups is a natural and necessary skills that we all share. In the early 2000s, there's a lot of discussions and research on using the molecular techniques, namely the cDNA microarray, in order to classify patients' tumors, I would say, with different category, mainly on using the expression profiling. Since the introductions of Alizada studies on Nature on the diffuse large B-cell lymphoma, where in their team, they were able to classify diffuse large B-cell lymphoma into different categories. There are a lot of proliferations of studies and research, and the rates of the proliferations of these studies to classify tumors, cancers of various parts of the body into different molecular categories even become more than the proliferation of one of the aggressive tumor. Gene expression profiling is basically looking at and extracting the mRNA from the tumor and merging it with a control group, and then doing the DNA microarray on chips, and then looking if the tumor is expressing this particular genes or not. We can use a large number of genes. And this is that they will come up with a detail here showing the green color as well as also the red color, where the green color represents lack of proliferation, expressions, and the red one represents expressions. And the tumor is usually placed on the x-axis, while the y-axis is usually the different types of gene. To simplify these things, this is what's called the hierarchical clustering. Hierarchical clustering is being used in science for many years. The microbiologists are using it for many years to classify microbes, and also now it's becoming used for gene expression profiling in various tumors. And when this is done, it's looking at, this is just a simplifying cartoon, simplifying how the clustering is done, where the gene is placed here and the tumor is placed on this sides. And this is the hierarchical clusterings. Based on the hierarchical clusterings, we can classify the tumor. And this is one of the early studies that was done for breast cancer. This is the early studies on the 2000, where they classify breast cancers based on the expression profiling alone into these categories. These are the basal-like, luminal-like, normal-likes, and luminal. This is the luminal type A, B, and C. And then this has been refined as we go. And they also, in this early studies, they also looked at the outcome of the patients, and they were able to identify there are significant difference in the outcome between these various types. So the molecular classification of of breast cancer become evident early in the 2000s and become refined as we go in years. The first studies of the gene expression of pattern of breast cancer suggested 4 major molecular classes of breast cancer: luminal-like, basal-like, normal-like, which is not existed now, and HER2 positive. Subsequent studies have refined this molecular subtypes as we go. Among the 2 important types that gain a lot of attention in the literature is the luminal one and the basal-like, because these were not being evident when they examined the tumor under the microscope. So the potential value of this clinical of the gene expression profiling is to help us as a physician dealing with breast cancers to classify the tumor and also to assess the prognosis, and more recently to predict the response to various types of therapy. If we look at this breast cancers in this analysis, if you look at it, this is the basal-like, HER2 positive, and normal-like. They are basically ER negative, and this one is the ER positive one. So if you look at it, let's go back. This one is the ER negative. They are hormone insensitive, poor prognosis, and hormone responsive, the good prognosis. That's what is basically there. And this is the 4 major categories of breast cancer when we using the expression profiling: luminal A, luminal B, HER2 positive, and basal-like. And this table summarizes the latest data on the luminal A. In expression pattern, they are high expressions of hormone receptors of associated genes, and they are more with the luminal A compared with the luminal B. Clinical features, they represent about 70% of all breast cancer. They are ER/PR positive, and their luminal B tends to be higher grade than luminal A, and there are some of the luminal B, about 30% of them, they are expressing the HER2. And their treatments, they tend to respond well to endocrine therapy. They may differ from luminal A and versus luminal B, and response to chemotherapy is also variable, and their prognosis is usually better for luminal A compared to luminal B. HER2 positive represents about 15% of all cancer. They are ER/PR negative, and they are HER2 positive, more likely to have a high grade, and lymph nodes is also positive. They have high expressions of the HER2 and other genes, and low expressions of the ER, and they respond to Herceptin, response also Kaplan-Meier survival curve, also showing the statistical prognostic difference between these various types. I'll jump this and I'll go to there are many studies that looked at various subtypes and classifications of breast cancer. Luminal B in particular, this group in BC Cancer Agency, Maggie Chong and Torsten Nelson, they published really nice data on refining the luminal B. 30% of these tumors, they are luminal B, and they are expressing profiling show HER2. They call them luminal B, they call them luminal HER2 positive type. They are luminal B, but they are expressing them. The remaining part, they can be segregated from luminal A by using the proliferation index. They used in their study 14% as a cutoff to differentiate between luminal A and luminal A and B. Luminal A when it's less than 14%, and luminal B is more than 14 or equal to 14%. This has been refined more recently now in the latest data in 2014 by using a cutoff of 20%. But if you look at it from a perspective of a pathologist, there is no much difference, in fact, between 14 and 20%, because we are using our eyeball to evaluate those things. And jump this one. Basal-like is also gaining a lot of attention, because while basal-like cancers determined by expressions profiling are most of the time they are ER/PR negative, they are triple negative, but keep in mind not all triple negative are basal-like. And this is a wrong assumption if it's the case. If you see any triple negative, assuming this is basal-like, that's not necessarily true. In fact, majority of the triple negative, about 70 to 80%, are basal-like. But keep in mind there are some of the basal-like that are some of the triple negative are non-basal-like. And this also, Nelson and his team, they also looked at certain parameters by using immunohistochemical techniques to trying to define the basal-like. They use the EGFR and CK5 and 6. So if it's ERPR negative and it's triple negative, but EGFR is positive and CK5 and 6 and/or is positive, then they call it basal-like. And they have a really high sensitivity and also specificity approaching 100%. I'll jump this one. This is, also the basal-like itself is very heterogeneous, a tumor. And as you can see, this is the one types of the basal-like. It's really high-grade tumor, a lot of mitosis, a lot of geographic necrosis here. And this is also a lot of necrosis in this area, bizarre-looking nuclei. And they show high proliferation index that can approach around 80 to 90%. This is also the medullary type, where the breast cancer has a lot of lymphoplasmocytic infiltrates to them, and they have also hyalinized area, and they also show expressions of the CK5 and 6 by using immunohistochemistry. So histologically, the basal-like is very heterogeneous tumor. In the invasive ductal, medullary type, adenoid cystic, and metaplastic, they are all being lumped under the basal-like. Immunophenotype also, they are heterogeneous. They show a lot of variable expressions of various markers. Prognosis of them, some studies they try to identify and segregate between the basal-like and non-basal-like, triple negative, and they found the basal-like is in fact have poor outcome when compared to the triple negative non-basal-like. They share a lot of similarity in the outcome when you talk about 60 months in their survival. So in summary, basal-like cancer, they are a heterogeneous group, and with regards to the histological feature and immunophenotype, still there is no universally acceptable definition. So I will stop here at the questions. Do we make a suggestions of basal-like when we do the pathology report? The answer is no. We don't do that. Do we do a routine basal cytokeratin or EGFR to stain the triple negative breast cancer? The answer is, of course, no. We don't do that. There are some types that are special types of breast cancer, like lobular can be lumped, divided into luminal, HER2, and basal type. There are some medullary are always basal-like, tubular are always luminal-like, mucinous are luminal type. And this is just general molecular classification of the different special type. I think I will stop here, and because of the time, I will not mention this. I will not mention this table. This is the really summary table that shows the expression profiling, how immunohistochemical profiling to segregate between luminal B, luminal A, and HER2 and basal-like.
Because they are not having good radiology.
You think we are better than Americans? So we are better than we are better than Memorial Sloan Kettering and MD Anderson.
Wait a minute, but reviewing all the evidence, the national Saudi guideline based on the evidence-based health, from Ministry of Health, the guideline, it is not every year from 40 to 50. It is every 2 years. 2 years, yes. Even if it is 18 to 2 years. 18 months to 2 years.
Just last
from
statement.
40.
Last statement.
I'm the one with them.
Last statement. The screening should be a choice. You tell the woman the fact, and she chooses whether she wants to be screened or not.
And
screening is not a must. It's a choice for the woman. You tell her the fact.
Okay. We will have the last comment from Dr. Medina.
It's not that in Saudi Arabia. It is not a must. It's by choice.
This is if you wish that you put the evidence based.
Just I want Dr. Ahmed.